half of the patients that we treat for cancer will live for many years afterwards. And they, of course, do it with, or many of them do it with different complications. And this is one complication that could be devastating for the family. And just to show you that we can make a difference. I also want to point out the quality we've had at this conference, because we have a couple of hundred proffered paper and presidential sessions, and the two last ones you heard are poster session presentations. So it's really worth to look into what we can present at our more than 2,000 abstracts, the posters that are all over. Sometimes there's a tendency that those are a little bit in the shadow, but it's incredibly what good science and interesting science that are being presented here. Okay, I think it's time to now open for questions. And when you ask a question, please say your name and who you represent. Yes? Sorry, I think, can we put the microphone on, because it's a little bit difficult to hear.
I can repeat the question. The question was if all the users of aspirin were low-dose aspirin users. Is it better like this way? Maybe this way? I don't think it's on, maybe.
You need to switch it on. Use my one.
This one?
This one. The question was if all the aspirin users were low-dose aspirin users. In the Netherlands, aspirin is prescribed mostly for cardiovascular prevention, and that is the low-dose aspirin, so 80 to 100 milligrams.
Yes? Go ahead. First row. Yeah. Microphone.
I think it's not working.
This is not working? Okay. Oh, do like this then. Come on. We'll improvise.
Dr. Frouws, giving aspirin to patients who are undergoing gastrointestinal cancer treatments seems counterintuitive, that you're giving them a drug that is known to cause gastric distress. Is that possibly why you have such a low level of aspirin use in this group of patients?
No, the reason why this percentage of aspirin users is this amount is that it is because the users are only users after diagnosis. 60% of my population didn't use any aspirin, 8% used aspirin after diagnosis. So the rest was aspirin users already at diagnosis, and they weren't included in the analysis.
And Dr. Naredi, on the basis of this study, would you offer aspirin to your patients who are undergoing treatment for gastrointestinal cancers? Is this information compelling enough for you to change your practice or to continue your practice?
So I think this is a very good example where we really don't prescribe aspirin to all our patients, but looking at the population, I'm thrilled if I could see that more of the Swedish population from a certain age, 50 or 60 years, that's what we debate, actually would take low-dose aspirin to prevent not only cancers but also other diseases. So I would not prescribe it specifically to each individual, but I think it's amazing how a 100-year-old medicine, which might not even be approved today, I don't know, but there are really very little complications. We know that also from these meta-analysis of complications, and it can do good. Yep.
Hi, Caroline Helwig-Asco Post. Along the same lines, did you, maybe I missed it, but did you tell us what stage the patients were? Were these all newly diagnosed, early stage, or were they advanced? And also, how long were they followed to get this outcome?
The patients were all diagnosed, and after that we assessed the use of aspirin, and so it was cancer of all stages, because it's data from the National Cancer Registry. So all patients with the gastrointestinal malignancy were included.
That seems like it would kind of muddy the result because your advanced stage patients are not going to live as long as your early stage that might be cured. So, I don't know.
If you split it up, the effect of aspirin per stage, you still see the effects for every single stage?
Charles Bankhead, MedPage Today. I have a question for Dr. Lambertini. As you pointed out in your presentation, there have been previous studies looking at ovarian suppression. What new information do you think your study added to what we already knew on this topic?
Yeah, thank you for your question. Can you hear me? Yeah. We had in the past 12 randomized studies. 2 of these studies were presented in the last year. One is the US study called the POEM study that was published in the New England Journal of Medicine, and the other one was the Italian study that we hope to publish in the next month. And our study, the one that I presented here at ECCO, is a meta-analysis, so is a pool analysis of all these randomized studies all together. So this is the news as compared to, to every single phase 3 study.
My name is Susanne Billig, Medizin Medien Austria. I have a question at Dr. Robert. There are patients who have a high tumor burden and experience rapid progression. How long does it take for a response?
Can you hear me? Yes. Targeted therapy usually works really fast. We can have responses as early as 1 week after the initiation of treatment. So, you know, now there is a big debate on which treatment should we begin with when we have a patient with metastatic melanoma. And definitely the category of patients with threatening metastases, usually we go to targeted agents because it can act really quickly as compared with immunotherapy.
Charles Bankhead again, MedPage Today. This is a question for Dr. Robert and also for Dr. Naredi. Given the current excitement surrounding the immune checkpoint inhibitors in melanoma, could you sort of provide some context about these results? What the results with the immune checkpoint inhibitors obviously were not available when the trial began. What impact do you see these newer drugs having on these results and the use of the agents that were evaluated in them?
I think it's totally justified, this big excitement about immunotherapy, but we should also be excited by these results. We don't want to treat our patients with something, we want to treat our patients. So if we see these results with results with the landmark of 2 years, it's excellent results. Now the respective position of immunotherapy and targeted therapy, we have very comparable results in terms of overall survival and with anti-PD-1 and this combination. So I think we really need to evaluate that prospectively. Should we begin with one or the other? So except the population of patients you were referring to with very high tumor load or compressive metastases, we begin with targeted agents. But for the other population, especially the low LDH patients who respond well to both therapy, there are already some trials who evaluate beginning with immunotherapy or targeted agents and then switch at progression. This is something that we try to set up in the EORTC frame. This is really something I would like to do because right now we don't have the answer. And you know what is very exciting is that when we give targeted agents, we remodel the immune landscape of the tumor, and we really have now the experience that in some patients we do a treatment, then we switch to another, and then we go back to the same initial treatment and it works. So now we are in an intense discovery era where we really have to be excited on new treatment, but not have ideas that there is only one treatment that is going to work. We need to evaluate prospectively.
I totally share your views, of course. And I think it's important what you said at the end, that behind our excitement is a lot of lab work, experimental work right now. And if you take one of these drugs, not the one affecting the BRAF mutation, but if you look at the one at the MEK mutation, it's so fascinating because we have several different drugs to use in the clinic, and they are all not the same. So when we do our animal models and can take a tumor from a patient, put it into an animal, and test against these different inhibitors, it could very well be that the one that didn't work the first time was not the one to give. It's one of the other 6 that we have in our agenda. So when we go back again after 6 or 8 months, we have an effective treatment. And this way we must start to consider even advanced melanoma as a chronic disease. We must think differently about how to use these different combinations. So there's a lot of work going on behind, and I think there we are not that thrilled. There we are more scientists again, looking very tough at the data we get.
Good morning. Damien Coulon from Le Quotidien du Médecin. I got a question for Dr. Robert. When you ended the study in 2014, did you switch patient from the single therapy to combination therapy, and what was basically the effect of this switch?
Yes, when we had the result that became the final result at interim, we authorized the crossover. And, but it was not mandatory, like some physicians who had patients doing well in vemurafenib, they could leave the treatment like that. But I think most of the physicians switched over to the combination. I don't think we have enough patients and or enough insight to really say what the effect was. But we have some data on real-life experience which tend to say that it's a benefit to switch. But from this study, I don't have definitive answer. But it's small numbers of patients. But because what we had, what previous studies had suggested with smaller effective study, it was that when it was initiated with a BRAF inhibitor and then progression under BRAF inhibitor, the combination was less effective. Now we have some real-life experience suggesting that if you switch before the progression, it's a benefit for the patient. That's all we can say right now.
Let's take some questions here.
Yeah, Ed Sussman with the Oncology Times again. Dr. Lambertini, in your study, you noted that the treatment with the yeah, those things is considered experimental. Do you think your meta-analysis should change that designation? And Dr. Naredi, would you comment on that as well?
Okay, thank you very much for your question. I think that now there is enough data to use this strategy, and in Italy we just changed our national guidelines that will be released in 1 month, and will support the use of this strategy in breast cancer patients.
I'm not the right person to say whether we should change the practice, because this is not my field, but as a clinician treating patients with chemotherapy and other treatments that can make patients infertile, I think it's the focus that this is really a very, very important question. And I would more be like a bystander taking an active part, saying, yes, we need to give this kind of research more focus. When others who know the field better say, now it's time to make this routine, yes, then we do it. But this is, it's very, I don't know the exact data from all these things, so I'm careful there. Mm-hmm.
Hi, Caroline again, ASCO Post. Dr. Robert, since Dr. Grobe is not here, could you comment on the quality of life data, which apparently is out there?
Oh.
His name is up here, but it's not presented.
When is that presentation going?
I don't know exactly when. It's a poster? Yes. So we did an evaluation of the quality of life, actually in the 2 phase 3 study, Combi-v and Combi-d. it's like a multi-parameter evaluation. It's always complicated quality of life. And finally, we found that in the combination arm, it was always better than in the monotherapy arm. And it was always above the 0 line. And even at so there was an evaluation over time, and then at progression. Because of course, when patients progress, you know, it can influence the quality of life, I mean, psychologically. And it was always better for the combination than for the single agent therapy.
One more question. You said this is the longest survival in this population. Just to be clear, you're talking about the BRAF mutated patients?
Metastatic melanoma patients.
Any metastatic melanoma
Yeah.
patients, not just the mutated.
We don't yet have the overall survival for other phase 3 trials. For example, of course, we are all waiting for the combination NIVO and EP, but right now we don't have.
It's,
I'm Sylvie L'Apostole from APM in Paris. I have a question for Dr. Robert. With the experience you have today of the two options, immunotherapy and the targeted therapies, what could you say about the long-term survival? I understand that you don't have
So I
old
just
data.
said, I mean, it's very comparable. Right now we have the data from the phase 1 with anti-PD-1. So phase 1, it's not randomized. And it's a little bit less than 2 years. Here we are a little bit more than 2 years, so we have to wait for the randomized study. So right now I cannot say more. What might be different, but we don't know yet, is the combination of immunotherapy. But single agent anti-PD-1, it seems to be almost comparable, maybe just a little bit less, you know, but it's 24, 25. It's very comparable. So people have to know that, because now we have some patients who come and they say, I want immunotherapy. I mean, it's important to tell them that you want something that works. So right now, we cannot know. We have to do this kind of trial to begin with one or the other treatment.
I think we take a question from the back first. So.
Pierre de Waal from Belgian Oncology News. Question here for Dr. Robert. What is now the sequence for the treatment of the patient? But because you say we treat our patient, we don't want to treat with ipilimumab or so on. So what is the sequence, the best sequence for the patient with melanoma?
Okay, so the best sequence, we don't know. It has to be evaluated. What do we do practically? In France, for example, we just had the PD-1 agent authorized, and they have to be treated with a treatment containing a BRAF inhibitor first line if they have a mutation of BRAF. So we have to use, so there is no question, if we don't do a clinical trial, we have to use an anti-BRAF treatment for these approximately 40% of our patients who have a BRAF mutation. For the other 60%, then we go up front with an immunotherapy, because we don't give an anti-BRAF for a patient who is BRAF wild type. So for the countries where you have a direct access to immunotherapy, whatever the mutational status here is, then it's up to the physicians. And my deep thinking is that it has to be evaluated, because right now we don't know.
Okay, front row.
Ed Sussman again for Dr. Robert. Is there any consideration of using your combination therapy with something like nivolumab in concurrently, or do you still just want to do sequential failures?
So this is evaluated in a clinical trial context, of course, combination or sequential, and of course this is an obvious clinical design trial. It might, however, not be the best thing. Remember when we had, just some years before, we had BRAF inhibitor single agent, which was a major step forward, and ipilimumab. So very quickly we tried to combine. And then we had to stop for toxicity, liver toxicity. We have clinical trial. We already did some, and other collaborators too, so we'll see.
So there are no ongoing trials?
Yes.
Okay, next.
Can you tell us why, a little bit more about LDH as an indicator of prognosis and what that means for the patient and the physician?
Yes, it's very interesting, and I think we don't know everything about LDH, because initially we thought LDH was just a marker of tumor burden, like you have a lot of tumor cells, a lot of destruction of cells, and finally it might not be the case, because LDH you have several isoforms, and it seems to be more a biological marker. And it has been shown in some cancers, like for example colon cancer, the isotype 5 of LDH might be something that means something. We had a clinical trial some years ago with a drug that did not prove to have any efficacy finally, but it was really according to the LDH rate that we evaluated the patient, and at that time it was clearly shown that it was not always linked to the tumor burden. So it's clearly an indicator of prognosis, and sometimes it's not the patient who have the biggest load of tumor cells who have the highest LDH. But when we see a patient in our everyday practice, when we see high LDH, we don't like it. It's not good. And it is true, I mean, any treatment that you try, EP or combination of BRAF, all the most powerful treatment, they work less well in patients with high LDH.
Okay, I don't see more questions, so I think we conclude here, and thank you very much for coming.